Hello and welcome to another video on chapter 38 where we discuss the alterations of digestive function. In this video we're going to discuss complications that are common to all liver disorders and will include portal hypertension, ascites, hepatic encephalopathy, jaundice, and hepatorenal syndrome. Now I'm sure you've at least heard of one of these conditions, and any acute or chronic liver disease is going to lead to the most significant systemic life-threatening complications. So we'll talk about that process as we go through these slides. So let's start off with portal hypertension. This is when we have abnormally high blood pressure in the portal venous system that is caused by a resistance to portal blood flow. So if you remember from our previous video, we were talking about the veins here in the abdomen that are draining the intestines, the stomach, the spleen, and they're essentially all going to pull back, or drain back rather, to our hepatic portal vein. So this is the area that is really compounding this high blood pressure, and typically the pressure in here is going to be about 3 millimeters mercury, but when we have portal hypertension it's increased up to at least 10 millimeters mercury, and this could either be due to intrahepatic causes or posthepatic causes. When we say intrahepatic causes, we're talking about some form of vascular remodeling with shunts, thrombosis, inflammation, fibrosis of the sinusoids, biliary cirrhosis, viral hepatitis, or schistosomiasis, which is a parasitic infection. When we say it's posthepatic causes, it could take place from hepatic vein thrombosis or cardiac disorders that impair that pumping ability of the right side of the heart. And so what happens is blood will collect and pressure will increase within the portal system. And when we have that portal hypertension for a long-term period, it can cause pathophysiologic problems that are difficult to treat and can be fatal. So what we see is varices. And we've talked about this before in our cardiovascular unit, and it's when we're going to see distension and tortuous collateral veins develop. When we have prolonged pressure, these collateral veins can open between the portal vein and the systemic veins, such as the gastric veins or the esophageal veins, and even over the abdominal wall, which is what we see down over here. And this is known as caput medusae, where we have the distension of the veins of the abdominal wall, and this can also take place in the rectum, and we can develop hemorrhoidal varices. And because of the increase in pressure in these veins, we can also push all of that blood into the spleen and develop splenomegaly. And this is when we have an enlarged spleen, like we said, because of the high pressure in the splenic vein. In this condition, the most common symptom is going to be thrombocytopenia, where we have a low amount of our platelets, and can develop hepatopulmonary syndrome, which is what you see pictured over here, where we have vasodilation and intrapulmonary shunting and hypoxia taking place. The other condition that can develop as a complication is portopulmonary hypertension, and this is when we get pulmonary vasoconstriction and vascular remodeling. So stepping away from splenomegaly and talking about portal hypertension in general, vomiting of blood from a bleeding esophageal varices is going to be the most common clinical symptom. And so when we have a slow chronic bleeding from the varices, we can develop anemia or melena, and if those varices rupture, it could cause hemorrhages, and the vomiting can become more of a dark colored type of blood. To diagnose portal hypertension, we can do an upper GI endoscopy and evaluation of the portal venous pressure, and to treat it, we can use non-selective beta blocking drugs to reduce pressure within the venous system. Now let's move into ascites. This is when we start to accumulate fluid within the peritoneal cavity. You could see that taking place over here, and in this patient who has massive ascites with cirrhosis, you could see the distended abdomen And we can't see it pictured here, obviously, but we've got some dilated upper abdominal veins and an inverted umbilicus. And these are classic manifestations of ascites. Now let's talk a little bit about the pathophysiology behind this. Because the fluid is moving into the peritoneal space, we are going to reduce the amount of body fluid that we have available for our normal physiological functions. But this isn't a primary issue that just all of a sudden developed. This is usually caused by cirrhosis, and some other causes would include heart failure, constrictive pericarditis, abdominal malignancies, nephrotic syndrome, and malnutrition. So we can have development of ascites due to portal hypertension and decreased synthesis of albumin by the liver, and this causes capillary hydrostatic pressure to be greater than the capillary osmotic pressure, and that pushes this water into the peritoneal cavity. We can also have splanchnic vasodilation take place, and this is when we have an increase in nitric oxide production by the diseased liver, which decreases the circulating blood volume, triggering aldosterone and ADH secretion, which then will lead to sodium and water retention within the kidneys. And when we have bacterial infections taking place, that can move into the peritoneal space and cause bacterial peritonitis, which then is going to increase capillary permeability, causing us to lose more plasma into our peritoneal space, and ascites develops. Unfortunately, about 25% mortality takes place in 1 year if it's associated with cirrhosis, and causes, like we saw over here, our abdominal distension and increased abdominal girth and weight gain. So in attempts to treat this, we can give albumin, and we can use paracentesis to aspirate some of the acidic fluid for bacterial culture, biochemical analysis, microscopic examination, and also it's going to relieve some of the symptoms, but we also need to be careful so it doesn't lead to hypotension, shock, or death. And of course, as this is related to some type of diseased or dysfunctional liver, we want to restore that liver function, and that ascites will diminish spontaneously. Now on to hepatic encephalopathy. This is a neurologic syndrome of impaired behavioral, cognitive, and motor function. So what does this really mean? Well, the condition is going to start to develop when all of a sudden we have hepatitis take place, or this happens slowly while the liver disease is progressing. And the cells within our nervous system are going to be vulnerable to neurotoxins that are being absorbed within our GI tract. And because our liver is dysfunctioning, we're not able to remove toxins. The toxins start to alter cerebral energy metabolism. It interferes with neurotransmission and can cause cerebral edema. And one of the most hazardous substances is going to be ammonia. And we get that develops from the breakdown of proteins, and we're not able to convert it into urea because our liver is diseased. So it starts to build up. So some of the early symptoms that we see in this are changes with our personality, memory loss, irritability, disinhibition, lethargy, and sleep disturbances. And then as it progresses, we can have confusion, disorientation to time and space, flapping tremor of the hands, slow speech, bradykinesia, stupor, convulsions, and coma. And what we see here on the right-hand side are some of the compensated results in somebody who has cirrhosis. So we may also have these manifestations in conjunction with hepatic encephalopathy because it starts off with a liver disease. Now let's move into jaundice, also known as icterus, and this is caused by hyperbilirubinemia, and it could really result from three separate things. We have extrahepatic obstructive jaundice, and this is really an obstruction to bile flow. We also have intrahepatic obstructive jaundice, and we can develop hemolytic jaundice. So let's talk about each one of these and how they're going to go about as far as its pathophysiology to cause jaundice to take place. Starting with our extrahepatic obstructive jaundice, this is developing if the bile duct becomes occluded. Maybe it's through a gallstone, a tumor, there's inflammation taking place, and so that is going to cause the bile to accumulate in the liver and can enter the bloodstream. And because that bilirubin is not making its way through into the intestines, we end up with light colored stools. So we have this buildup of conjugated bilirubin within the blood, and that is going to increase the exertion of bilirubin within our urine. So we get a dark urine that is formed, and then we start to take that bilirubin and deposit into our tissues. Namely, we start to get a yellowing of the sclera of the eye, and then it starts to be deposited within the skin, and we'll talk more about that in just a little bit. Now let's talk about the intrahepatic obstructive jaundice, and this is going to involve disturbances in the hepatocyte function and obstructing the bile canaliculi. And as a result, we obstruct our bile canaliculi, and that is impeding the flow of conjugated bilirubin into our common bile duct to make its way into the duodenum. So that too is going to cause a hyperbilirubinemia, which then leads to jaundice. And lastly, in our scenario of hemolytic jaundice, we may be having excessive lysis of red blood cells. Maybe it's autoimmune, or we have toxins within our body, such as arsenic or copper, causing it to take place. But what that is going to do is cause an increase in unconjugated bilirubin through metabolism of the heme component of the destroyed red blood cell, and we start to see that exceeding the conjugation ability of our liver, causing the blood levels of that unconjugated bilirubin to increase, and that causes jaundice. And you may be wondering, what is the difference between unconjugated and conjugated bilirubin? I put this kind of small here as this should be review for us, but when we first break down our red blood cell, we know that we're going to break down heme and globin. And so that heme component creates an unconjugated bilirubin, and we have albumin there for us that helps it move through the bloodstream to make it over to the liver. And after the liver processes it, we get conjugated bilirubin, and it's really just going to be this little change over here, but then we are able to put it within our bile, sending it over to our duodenum, and then it makes its way into our circulation once again. Now, when we have an increase in the unconjugated hyperbilirubinemia, we are going to understand that it is not water soluble, and so we can't excrete it within our urine. So we may see a change within the color of our urine here too. All of that bilirubin is going to end up in areas of the sclera and the skin, and the reason we really get that yellowing of the skin is because bilirubin is going to start to attach to the elastic fibers, and we can also have it cause itching because bilirubin irritates the itch receptors here. So to diagnose this, we're going to look at the serum levels of bilirubin, conjugated and unconjugated, and see if there's a history of cirrhosis, hepatitis, diseases of the gallbladder, or pancreas disorders. And for treatment, we want to find out what the cause is and treat that. The last topic we'll cover in this video is hepatorenal syndrome. And this is a renal disease that usually is caused by portal hypertension, cardiac impairment, or some other type of circulatory alteration that's associated with an advanced liver disease like cirrhosis. And you could see some of the effects of liver disease depicted in this figure on the right-hand side here, and you can see how it is all linking back over to the nephron within the kidney. So we have two different types here. Type 1 is going to accompany a sudden decrease within our blood volume, and that is because we've got a massive GI or varicose bleeding and hypotension. And this could be caused by the bleeding itself, resulting in the low blood volume, or it could be from peripheral vasodilation. And with the decrease in blood volume, we are going to have less renal perfusion and glomerular filtration, and this causes oliguria. Type 2 is going to be one that develops more slowly, and it's going to be related to ascites. So we'll still get that low blood volume because all that fluid is moving into the peritoneal space. And so in both of them, we'll see oliguria and complications of advanced liver disease, which can include sodium and water retention. And that typically we'll see with the ascites and peripheral edema. We've got hypotension and peripheral vasodilation. And we'll also see some other manifestations that are similar to some of the other conditions that we've discussed in this video. So we'll see most of these patients will have jaundice, peripheral edema, or GI bleeding present.